Hello, thanks for watching this video. Wanted to put together a quick video here to help you understand maybe your dizziness that you might be affecting if you're having vertigo or some other form of dizziness where you're needing to receive treatment. Uh, to understand the difference between them, there are two typical causes if your inner ear is affected. One, true vertigo, typically associated with positional-based vertigo, so BPPV. This is going to be the thing that's more tied to when your doctor refers to crystals in your ear. This is going to be more positional based and results in extreme dizziness in many cases and has the sensation of the room spinning. That usually lasts about a minute or so. Sometimes when you're doing it, it seems a little bit longer. Sometimes it is longer based on the type, but it is different from vestibular hypofunction, which is a presentation when one ear is affected, sometimes both. Oftentimes one ear rather than the other. The mechanism isn't working as well compared to the other causing dizziness. So its communication with the brain in response to movement and different things will cause more of like a blurred vision and general sensation of swaying and dizziness, and may come from a number of other conditions and causes. So we'll start with BPPV because it's the most commonly referred to and a lot of times, and hopefully the quickest to treat. Luckily, BPPV responds extremely well to some repositioning maneuvers. A handful of treatments, and you're usually good to go. It results in extreme dizziness with beating of the eyes called nystagmus. When patients move into a specific position, it often creates the sensations of the spins or the room is spinning around you. What happens with BPPV is the crystals that are in your ear are actually hair cells, just like you might have hair cells in your nose, or in my case, your ears as well, that just respond to a stimulus, in this case, you moving around in space, and communicate with your brain where you are, essentially, where your head is. So I include a little picture of this little marble game to help kind of describe what those repositioning maneuvers are doing, along with a picture of the inner ear to kind of help you visualize what you'll be doing when people are moving you around. Why does this work? So those hair cells are on the right, you see this little container here that's zoomed in, and that's the autoconia. Those are the crystals. Those are the hair cells in that little container, and that tells your brain when you move linearly, so forward, back, side to side, where your head is in space. And those three little canals there tell your brain where your head is in different angular positions, right? And those three canals are filled with fluid. That fluid, imagine like you're using a level in your home to move around. That fluid moves and displaces as you move, and that movement tells your brain where you're at. When you either hit your head too hard, you move too fast, sometimes those hair cells can get like knocked loose, and then they move into one of those canals, and it disrupts that fluid movement and the communication to your brain. That's all that's happening. That is what's causing that sensation of dizziness. Essentially, the initial communication to the brain as that fluid is moving, when you're moving your head, is telling your brain where your head is in space. That is going to be disrupted. Your brain is then going to correct, and that's why your eyes are jumping, because your eyes are thinking you're over here, but really you're over here. And that movement stops when the fluid in your ear stops moving. Okay? So all we're doing when we're doing our repositioning maneuvers, if you imagine like this little marble game where you're picking it up and moving it around until it goes into the appropriate hole and goes back into that bottom, that base where it came from, the same thing's happening just over here with these canals in your inner ear. It's stuck in one part of the canal. I'm moving you over here. It kind of rounds the corner, flip you over, it moves back, wait until the dizziness is gone, and then boom, it's back where it started, and symptoms should be better. You may not clear all of them once. You may clear some of the otoconia, some of the hair cells, some of the crystals. At first, you might see a pretty significant or maybe a moderate relief in symptoms, and then you do this a handful of times. You do it a little bit more frequently, and you're better. With this treatment, just keep in mind, once one of those hair cells is knocked loose, it is still just, when it goes back in that container that it came from, it doesn't necessarily stick back in. So it is possible for this to be a recurring condition where you had it once, you don't have it for a long period of time, and then something happens and it comes back. Okay. as opposed to vestibular hypofunction. So hypofunctioning of the inner ear, where it presents a little bit differently, usually not extreme dizziness, but because that's affected on one ear, it's not the same thing. It's not as structural in regards to the hairs, the crystals. The crystals usually aren't affected with this. And it can come from a number of other conditions, right? It can come from infections. A lot of times, if you have a lot of ear infections as a kid, a lot of swimmers' ear, you can end up developing like neuritis in your ear. Other just general infections, if you have chronic, just kind of chronic medical conditions that can lead to infections, this can lead to hypofunction on one side of the ear. So it's more of a result of inflammation. And for these, repositioning maneuvers won't cure you. It's not going to be enough. How you treat this hypofunction, you typically have to train new pathways in your brain to respond to what's happening that your ear is not being able to catch up with, right? So you've lost some kind of response. It's not as effective. Now you're training your brain to work with what you do have in your ear. So when you're doing this, you're going to have some form of head movement. Sometimes you see these little head shakes. There's a lot of different things that you end up progressing, making more dynamic, making more functional with this. But you always want to go to a point where you're just provoking symptoms. A lot of people use a 3 out of 10 scale just to kind of get a gauge on how intense this dizziness should be when you're doing the exercise. At first, I would recommend just barely touching it until you get a better grasp on how far you should go, because if you overtrain, you're going to end up feeling pretty rough the next day. Sometimes you can have almost like a hangover type feeling the next day where you're just very drowsy. Your symptoms get a little worse. You feel nauseous, bogged down. So you want to just touch symptoms and then use the adaptation in the brain to recover. Then try again, and hopefully the second time you do it, it's a little bit better. And the more you do this, the more you kind of create that pathway in your brain to help with symptoms. But you do not want to power through, and it will take a little bit longer than it would with the repositioning maneuvers to fully recover. This last little slide here just kind of goes over the different things that you're keeping in mind when treating. That first one is what I was talking about before with the adaptation in the brain, where you have to facilitate that central or brain spinal cord compensation. So provoke symptoms, rest, and then stop. And usually that plasticity, that response in your brain to make things better, occurs in 1 to 2 minutes. So if you take a break, wait till you're symptom free and try again, most of the time you're doing that correctly, you'll actually immediately see results where you're starting to be able to perform the task for longer and with less intense symptoms. Habituation is also just repeated exposure to a stimulus so that your brain can adapt to it. So if moving targets in the background bothers you, starting in a room kind of like this one where it's kind of quiet and not many distractions, progressing to going out to treatment in a busy clinic room where there's a lot of moving targets in the background and music playing, so on and so forth. Substitution, so using the rest of your body's systems to kind of help return to full function. So maybe working on balance, just like through your feet and things without targeting your ear, and postural strength, different things to kind of just help your overall functioning, to help substitute for what your ear is lacking to help. The most common version of this is, everyone knows this, has been told this at some point in time, where if you're having a hard time balancing, you focus on a target with your eyes, you're actually substituting your visual system to help you with balance in that case, right? So a lot of the training, a lot of times people become vision dependent and their inner ear isn't helping them as much with balance. So that is a perfect example of substitution. And then cognition, anytime you can add a cognitive challenge, it's going to help facilitate that neuroplasticity in the brain and form these connections, because you're activating more areas of the brain at once. So a lot of people do like to count back from 100 or other tasks. Sometimes they're little cards with words you repeat. Any cognitive challenge that you can do while working on this hypofunction will help improve your outcomes. That's all I have right here. If you have any questions, reach out to the appropriate healthcare provider, and I hope you have a speedy recovery.